Hello everyone, and thank you for joining us today. Today's webinar is the Complex Regional Pain webinar, and we're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by CIRPD, ourselves, and Pain BC, in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Community Gaming Grant Program through the BC government, as well as through donations and memberships to our organization. And as mentioned, my name is Tanya, and I'll be moderating the webinar and handling the Q&A session today. And our presenter is Dr. Andreas Goebel. Dr. Goebel works at the Walton Centre for NHS Foundation Trust in Liverpool as a consultant in pain medicine and as an assistant professor in pain medicine in the University of Liverpool. He is director of the Liverpool Pain Research Institute. He's initiated and together with Chris Barker led the UK guidance on complex regional pain syndrome, which has picked up endorsement by over 20 UK professional organizations and colleges. He has developed the concept of autoantibody pain in order to explain some of the causes for complex regional pain syndrome and perhaps also for other chronic pains, and he has successfully conducted clinical trials with immune modulating treatments. I will hand it over to you, Andreas.
Thank you very much, Tonya, and thank you for the organizers for inviting me to speak on this webinar. So the webinar is about this complex regional pain syndrome, and this is my sort of special research and also clinical interest. My background is anesthesia, and I've had some immunology training in addition, and I work as a consultant seeing patients, and then half of my time I'm a senior lecturer, which in North America is called assistant professor. The purpose for the webinar, I've taken that from your website, to bridge the gap between current research findings and information requirements within the patient community. I'm hoping to present you with a little bit of the research done over the last couple of years in complex regional pain syndrome and discuss this a bit and perhaps interpret it a bit. I will then also provide an update on current developments in the field of immune studies in CRPS. At the end, I'd like to outline some recent ideas about efficient treatment pathways for uncommon severe chronic pain conditions. I mean, ideally, I'd love to do this in a workshop, but I invite you to think together with me about this. The pathways are really important because people, not just with CRPS, but also with other chronic pains that are not so common perhaps, get really lost if there's no good pathway. And I'm going to show a little bit what we've been doing here in Liverpool. And maybe there will be some feedback. I know afterwards perhaps I'd be interested to hear on about your thoughts, how this can be maybe translated. So talking about complex regional pain syndrome, I think overall this presentation will be maybe half an hour, between half an hour, 45 minutes, and I understand then there's some time for questions. Complex regional pain syndrome was first properly described in the American Civil War. This is a reenactment, and you can see that the battle lines were drawn quite close to each other, and so there was also some new precision bullets developed just a couple of years earlier. So this was really carnage. A lot of people died, as you know, and there were many nerve injuries. And William Mitchell, who is an American poet and doctor, led the neurological hospital for the Union States, and he sampled these cases who had a partial nerve injury and developed this interesting condition from his perspective, which was associated with a very high pain intensity. Nowadays we know that only few of these complex regional pain syndromes develop after nerve injury. The vast majority develops without any nerve injury. It can develop after any type of trauma, after a twist of an ankle, or even after bee sting. In about 5 to 10% people develop this severe limb pain without having experienced a trauma. He described really in very, very good language, I think, me not being an English speaker, but people tell me that English native speaker, his observations, and they were really, in part, they still describe our puzzlement about this condition. And in the acute stage, this can look like it does here on the left side, and one wouldn't believe that that resolves and basically becomes a normal hand anymore again, but it will. So skin can be red or mottled and sometimes pale, and the skin can look different, can look shiny, and there's swelling, and one has to distinguish, is this due to the injury or is this due to this nerve condition, complex regional pain syndrome? In the chronic stage, so after a few months, this looks completely different. And normally it looks like this, as you can see here, the left hand, so what you see on your right side, which is the patient's left hand, is affected. You don't see that much. There is some maybe bluish discoloration and a little bit of swelling. And if you go even later, or sometimes some people resolve almost with their swelling after 4 or 5 months, at that point you might not see anything. But unfortunately, in chronic complex regional pain syndrome, so once this has gone on for maybe 6 months or a year, although you can't see that much anymore, you can still see something, but not that much anymore, the pain may remain quite high, as high as in this dramatic picture here. And it's been long thought that clearly this, since there's nothing, not that much that can be seen, this must be in the brain. We come back later to that we think that's probably not true. So these are the diagnostic criteria which are now accepted throughout the world and have been adopted last year, I think early last year, by the International Association for the Study of Pain. They used to be called Budapest criteria. Now they're called, for the International Association for the Study of Pain, IASP. They're called the new IASP criteria. You can see there are 4 criteria up. Patient has to have continuing pain disproportionate to any inciting event. It affects limbs, really. The patient has at least one sign in 2 or more of the 4 categories which you can see below. There are 4 categories, so at least one sign in 2 or more of the categories. Sign is what the doctor sees, whereas symptoms are in C, is what the patient reports. So the patient reports at least one symptom in 3 or more of the categories, and it's a diagnosis of exclusion. So under D, no other diagnosis can better explain signs or symptoms. That is important. We don't have a blood test. There's no, although X-rays are often abnormal, that is not pathognomonic for the condition. That means other conditions could be equally abnormal in a similar way. So you can't diagnose from an X-ray or from an MRI. And then these are the categories. Tonya, can you actually see my arrow there when I go down here? Can you see that?
Yes, we can see your arrow.
Okay, good. So this is a sensory sign. So people have allodynia, or that means light touch pain, or hyperalgesia, pain to deep somatic pressure, either as a sign or a symptom. And then they have color or temperature changes, swelling or sweating, and motor changes or changes in hair, nail, or skin. And then one can do these ticks here, and we need to have at least 2 ticks in the sign category and 3 ticks in the symptoms. Okay, so an issue is clinically that and if patients listen to us here who have CRPS or who had CRPS, then they might know that it is not straightforward to have this diagnosed. And one reason for that is that as you've seen from the Civil War, this is can arise after any type of trauma. So you can have an ingrown toenail, for example, and that develops into CRPS, where the ingrown toenail is the trigger. And then you're with your podiatrist, and sometimes if the podiatrist is not familiar with the symptom, which he sees maybe 3 times in his life, so one can't really blame him or her, then it might take a long time until he says, well, this is odd, this behaves somehow different, whereas one would love that this is recognized early so that the patient can be reassured and the patient would know what's going on at least. Yeah. We've done this UK guidance in order to try and address this, and we've contacted all the professional organizations from all these professional backgrounds and have asked them to consider to have to endorse this guidance so that these medical healthcare professionals have a chance to be reminded that very rarely what they normally see might be something completely different than what it normally is. Yeah, so it's not an ingrown toenail in this case, it is sort of a developing CRPS. And the GP in Great Britain is really important, and we felt the GP should have center role here rather than the secondary specialist. So GPs knowing about this would also be very important. So this is the cover page of our guidance for complex regional pain syndrome, and you can see all these nice little logos where people have organizations have endorsed them. By now there are even more. So why doing complex regional pain syndrome research? It is an important area of research because a lot of, when compared to other pain conditions, a lot of people will have severe pain, and it's often without so many fluctuations, and you can contrast that with some headaches, which can be severe, but as an entity itself, it's not always as severe. Complex regional pain syndrome, if it does fulfill the Budapest criteria, is often really severe. We can't treat it very well, unlike, for example, migraines, which we have some treatments. We have no good specific treatment, medical, pharmaceutical drug treatment. We can treat with an implanted spinal cord stimulator, but overall we are not happy with the choices we have. We don't understand why people get this. Finally, when I first decided what to focus on for my research, then this was important. One can see something, meaning that people believe it a little bit more. It's hard for someone who's got chronic pain to have his or her pain believed, and it's helping to have a road in here. And in a few pain conditions, including complex regional pain syndrome, one can see something. There's color changes and swelling, and sometimes changes in the skin and nails. There's also the exciting challenge of overcoming, of doing some additional work. Recruitment obstacles can be overcome. It's a rare condition, so one has to develop systems to do that, and that's quite exciting, I think, because one has to communicate quite a lot with other healthcare professionals. And then also it's one of those prime examples where 20 years ago a lot of people wrote about how the psychology pre-morbid, so before the condition starts, psychology would be so important. These were all poor evidence trials, but one still hears that once in a while today, and so one can, it's an exciting challenge to confront that. And one hopes that with this research that some of the methods that people use might be translatable to other chronic pains. I have, to follow the first objective for this webinar, I have looked at papers that have been published over about the last year, and about 300 papers were published on PubMed. I have done a similar shorter presentation for our local CRPS group, and I was surprised to hear that people don't use PubMed. And I know that some patients will listen here as well, so I feel that for patients this is a great source of information. And these are all papers, virtually all papers published ever, and certainly any new papers published that can be seen on this online system. So if you type in there complex regional pain syndrome, then you will find quite a lot of papers, and you see an abstract there for each paper. You can click on these papers and you see an abstract, and it is a good way in to see what is science currently doing about this condition. When you do this, then you should keep in mind that papers may relate to either early CRPS, usually defined as less than 6 months or less than a year duration. So that is that condition which generally gets better, we've discussed that earlier, or later CRPS. And the results and the treatments should be quite different. So it's important to keep that in mind. And further, it is interesting to, and one should keep in mind this thing, the impact factor. If something appears in a journal that has a low impact factor, that means that generally, it's not an absolute, but generally, probably the quality of the publication isn't quite as good, and the process of review is not quite as rigorous as for journals with a high impact factor. So the impact factor does play a role. You can't see that on PubMed, but you can Google the impact factor. You can see the journal on PubMed, and then you can Google the impact factor. So these are the number of publications for CRPS. This was done, I think, in August or September, so 2015 is not complete, but you can see that there's sort of a slow trend upwards in the number of papers worldwide published on this condition. These are the themes over the last year. To start with, there are many case reports, and they're usually in low impact factor papers. People just see an amazing case. That case means like someone got a CRPS after a bee sting, for example, and maybe they thought no one else has reported on it, so people do report that. That is interesting, but it might not help us so much further on to understand the condition. Also, people report on novel treatments, but if you see that something is a case report, then it's important to understand this is very early research. One cannot give very much on this. This needs to be confirmed, and most of the studies of the 250 studies or so in the last 12 months have been case reports or showing just some novel treatments in just a few patients. A number of another common paper type are hypotheses and reviews. So people do reviews, and that's important, and it's good to see that because one gets an overview about what people think about the condition, but it's not new research. Then there's been quite a number of papers now on this condition appearing in other racial groups, especially from Asia. While traditionally this has been mostly diagnosed and treated in Caucasian people. There's and I'll come back to that in a moment. There's some interesting research on an animal model. There's some interesting negative research on the largest trial ever done so far, I think, in CRPS, a immune modulating drug which was thoroughly negative, didn't work at all. Bisphosphonates have been discussed, come back to that. And there's a few others. I won't go into everything in detail for now, and I'll just go into some of the papers now. Now, when looking at papers again, it is helpful to keep in mind when looking at mechanisms that the mechanisms can be either peripherally in the affected limb. So CRPS is a post-traumatic condition. And obviously there's some swelling, and you've seen the picture of the hand earlier, so something is not going right here, and people look at what it is that is not going right here. But then also people look at what's happening in the spinal cord and in the brain particularly. Spinal cord, our methods are not that good, so often people look at a lot more in the brain. We know that the spinal cord nerves are very much involved in augmenting, almost like a transistor, in the electronic transistor, the signals that come from the periphery. Without this augmentation that's happening here in CRPS, probably people wouldn't be in so much trouble. And then there's probably a different type of augmentation happening in the brain. and people often feel that their limb doesn't really belong to them and that it feels awkward and awful, and that's happening in the brain. Something changes there. Why? We are not sure. What changes there is not structural in the brain or in the spinal cord. Nothing gets destroyed. It's not like rheumatoid arthritis or diabetes where cells get lost. It's just the way these cells work and organize themselves is different, and that can revert to normal when the pain goes. But we don't know what exactly is steering this whole process. So one of the interesting papers that came out over the last year is that in the leading group looking at animal models, trying to see how animals behave when they get a trauma, this group has found out that if you put the animals prolonged into a cast, they will take longer to get better. And that's something we know from CRPS research, that prolonged immobilization, unnecessary immobilization, sometimes it's needed, but if it's unnecessary, it can prolong suffering. It probably doesn't cause any permanent damage, but it can prolong suffering. And what this group has shown is that if these animals after a trauma, if they mobilize early, the whole inflammatory process gets much quicker resolved. Another issue that I think is really interesting, I'm sure we will find more also in other pain conditions over the next years, is that there are some mild systemic changes in this regional pain condition. And you can see in the left side a tilt table test. This particular study did not appear in the last 12 months, but 2 additional studies appeared in the last 12 months. But I'm quoting the first study that ever came out on that. So if you tilt table someone, so people are fixed here on that table, and then the table is tilted upwards, then in a non-CRPS patient you can see some changes to blood pressure and also to peripheral resistance, so how the arteria and veins react. And you can see here already there is some obvious difference in the CRPS patients. And that must indicate that there is not just a peripheral, not just a regional element, but there's a systemic element. Something is changing the way the heart functions in the very mild way, not in a threatening, not in a concerning way, but something systemically is going on that might help us in the future to understand the cause better. Another paper, this is from us, showed that and that's something different. What you see here is we looked at the placebo response in trials in CRPS, and these are all the suitable trials ever done in this condition. And you've got groups here, 1 group, 2 groups, 3 groups, 4 groups, and this is the time when after a certain intervention, for example a block or a drug, the outcome was measured. So in these 5 trials up here, the outcome was measured within minutes or seconds. Here then within a week, so people got an intervention, and then within the next week the investigators measured how much pain relief patients had. Here 3 to 4 weeks, quite coherent group here of results, and here more than 6 weeks. And what this shows overall is that there's virtually no placebo response in people who have long-standing CRPS. The overall placebo response in all patients is about 4%. So there's and you might know that people say, oh, if you have pain, there's a strong placebo response, and that is true for some pains, but it seems to be not true for CRPS. And also we know now it's probably not true for some other conditions such as fibromyalgia, but this is the first time this has been reported for CRPS. So to give someone with long-standing CRPS a placebo pill will probably not work. It's probably not really advisable looking at these numbers. There's an issue within minutes after an intervention that might be different. People might say, oh, there's pain relief, but it doesn't last. It's not meaningful. Other topics that have been discussed include brain imaging. This is always interesting, and not a new physiotherapy method. We are not yet sure whether this could maybe relieve pain. It's not yet enough out. There's some reports from immunization in Japan, which has caused vague pains it doesn't really, when looking directly and carefully at it, it doesn't really look like that really S was caused. And it's unclear why these reports appear, but really looking carefully, some pain was reported more frequently than the investigators thought. It's probably not CRPS, but it has raised quite a bit of concern, these reports from Japan. Bisphosphonates are a new type of drugs that can be used in early CRPS up to 6 months and I think are probably effective. Now, I've got a conflict of interest because since I've been chairing the UK guidance group, I've also then later been consulting a industry that does produce these biphosphonates. So therefore, take what I say with a pinch of doubt, please. When I was chairing the guidance group, I made that assessment then that I think looking at those papers, and there were 5 randomized trials in the past, that looks effective to me. There are 2 large trials out now, and we'll get a good answer probably within the next couple of years. And there is a little bit out about psychological factors. Most studies show there is nothing at all. And this study is a good quality study that shows there is maybe anxiety can explain a little bit about how the course of CRPS is after trauma, at least the early course of CRPS. But that doesn't mean that anxiety is causing it. Yeah, it's a weak factor, but it's still maybe a factor. So if people are extremely anxious, maybe they're not doing as well. Why? We don't know. Doesn't mean that only anxious people get CRPS. So looking at the immune system now, this is my second topic for this talk. Most studies have been looking regionally to see whether there are any abnormalities, and indeed there are. If you take a little suction device, a vacuum that applies a little bit of negative pressure here over small areas of the skin, and then some of the interstitial fluid that is in our skin is drawn out with that suction, and you analyze that fluid, then you'll find that in the involved site there's an increase in inflammatory mediators. Yeah, not terribly high increase, but there's some increase. So there is some type of special inflammation going on in the periphery. This is now all not absolute new research. I'm now coming basically to the next topic, which is talking about the immune system and where we stand with our knowledge there. We have been looking at autoimmunity, and there are a number of different autoimmune mechanisms. It means that the adaptive immune system might be in some chronic pain conditions directed against the own body. If you take some serum from patients and purify it and get the antibodies out that are in there that we all have to fight infection, and if you inject these antibodies to mice, then the mice behave slightly differently in the open field. That means they don't rear as much, they don't seem to be as happy when they have been injected with CRPS-derived antibodies as compared to control-derived antibodies. And more recently, we've shown that if you then, under anesthesia, give the mouse a very small trauma here in the limb, kind of mimicking CRPS, so you give them these antibodies from the patients and then you give them a small trauma, then these mice will develop something that is some features that are important in CRPS, only those that are injected with CRPS IgG. So it is possible that this is an autoantibody mediated disorder, and I'm showing you now a little cartoon which Scott Osborne did together with me, one of our PhD students, to explain this a bit more. What do we need antibodies for? Why do we have those? We need them in order to fight infection. That red guy is a bacterium which will be taken up by the APC, the antigen-presenting cells, and presented to the adaptive immune system, the Sherifian T cells and B cells. And the adaptive immune system then produces these antibodies, and it really works like that in some conditions, like in pneumonia, and that's almost like a gun that can then bind to these bacteria and cause cell death. And how do these antibodies do that? They bind to certain structures in these bacteria. Every antibody has its own structure that it binds to. And the binding cell death can be caused by all sorts of mechanisms. It can cause inflammation and then destruction of the cell. So what are autoantibodies for? I've said maybe we have autoantibodies in CRPS. It may be an autoimmune condition. So these are antibodies that bind to our own body. It's our antibodies binding to our own body, which isn't very nice. So generally, you've got self cells, so a kidney cell, for example, and all cells will die and will be born again. If a cell dies a natural death, the parts of these cells will be taken up by the antigen-presenting cells and will also be presented again, like everything else, to the B cells and T cells, but they won't be able to act on it because they are rendered tolerant in their development. They can't do anything, even so they're presented with this, because it's our cells. You don't want them to do anything. Stress, genetic predisposition, and environmental damage can break this tolerance, and now suddenly the B cell may produce antibodies against our own structures. So if this is a kidney cell, now these antibodies will go to the still living kidney cells, bind to them, and cause inflammation and tissue damage, and then kidney disease. And some kidney disorders are caused in this way. Now there's one final step to make, one final thought step, and that is there are a few rare conditions where you've got antibodies binding to channels. And their real problem is not so much that they cause inflammation. In some of these conditions, they don't cause any inflammation, they don't cause any tissue destruction. But they change the way these channels work. And you need these channels in order for the cell and the organ to work properly. So all they do basically is to change the way these organs work. In this case, they internalize the receptor, and now the potassium ions, which need to get out, can't get out as easily anymore. And this cell will now function differently because it has more potassium inside than it should have. And the idea is that perhaps in some chronic pain conditions this is happening, that you have antibodies which are not destructive, but changing functional antibodies, we call that, changing the way the cell works. So I've shown you some results from laboratory studies. What does that mean for our clinics? And I think it will mean something relatively soon. We are interested in assessing immune modulating drugs in chronic pain, in particular in CRPS. We've done some work in trying immunoglobulins, which is one immune modulating drug. For this drug, we don't know exactly how it works, but it seems to be reducing pain from between 0 and no pain, 10 as bad as you can imagine, a patient who usually say my pain is quite high, 8 out of 10, to the same patient saying it's maybe 2 to 3 out of 10 after 2 infusions of immunoglobulin. It's only a minority of people that responds like that, but it shows that in this group there's likely an immune mechanism involved, and it's great. It's the first time that some of these people can be treated properly, but more studies are needed. We are currently doing a large trial on this, and we have completed recruitment, and we are awaiting the results probably by the middle of next year. People go through the remainder of the trial. Another method that can be used based on these laboratory results is plasma exchange. So a little tube is being put to a big vein and it sucks up the blood, some blood, and then the blood is taken out here. The fluid together with some additional, the cells together with some fluid, some clean fluid if you like, is going to be reinfused. What's taken out is a serum, that's a fluid in the patient's body, and which contains the antibodies. So this works in some autoantibody mediated conditions, and there has been over the last 12 months 4 low impact papers that suggest that it could work in CRPS. Of course, there are other drugs, and I think people will start using this now and doing trials, and maybe also in other conditions. Coming to the final part of my presentation, I'm keen to speak about referral pathways. I think we are not very good with this necessarily. I wonder how it is in Canada with these rural areas around few towns. I just would like to show you what we've done. We have also quite a large area, not at all comparable to Canada, of course, but a large area around us, and where our center, the Walton Center in Liverpool, is the largest pain management center, and then there are other smaller centers. And we were keen to establish a pathway so that people who have severe CRPS can eventually be treated by us if needed, so that they're not just at home and don't know where to go, which really you wouldn't believe it, but that does happen. And so maybe you can think about it yourself. How would you achieve that? What would you do in your community, in your region to achieve that? We first spoke to everyone around us. We looked at the map literally and looked at this area in England, and then also Northern Wales, because that's part of our referral area. We contacted all the pain physicians and we invited them, we spoke to them about this, and also all physiotherapists and occupational therapists that deal with people after trauma, because they would be quite well placed to diagnose this condition early. And it was important then to get these colleagues on board and say, look, if you need help, you can send patients to us, to signpost people, to be like, to say, hello, here we are, you know, we are interested in this condition. For you, it's very rare. We see it all the time. And we've done that, and we've massively increased our referral rate. And I think people are generally happy with the system. They're not feeling that it's taken out of their hands, because they decide when to refer. And often it's better to treat locally in the first half year, but if things don't get better, then people come here, and there are additional things we can do. The setup of that pathway is important. And you see here, there's also something in addition that we've set up, that's telephone support. So in addition to setting up the pathway, we have done some further things. We've sent a diagnostic checklist to everyone. We've named regional specialists so that physiotherapists know whom to refer to. We've told the physiotherapists throughout the region they can consult with us if they're unsure, and everyone knows that they can refer to us if needed. And we've also done some outcome research. Finally, we've established, and that's in accordance with what we've suggested in the UK guidance, a long-term management plan, because sometimes you do everything you can with these patients, for these patients, all the treatments and everything has been tried, and nothing has really worked enough. And the idea in long-term condition management, there are many, many conditions that are like that, where people still have the condition, and is not to just discharge, but to provide a kind of loose lifeline, a loose contact for those who wish to have it, and many want to have it. So we established a telephone system, advice line, we called that. We've established an internal registry so that we can contact people ourselves if we feel that there's maybe new research out, but we've also done patient groups which we facilitated. Mostly this is for people to speak to each other once a year. Often there's a desire to speak to other people who have the same condition, and we can use the registry to contact these the people and invite them. We've not seen this to be overused or abused or to be wrongly used generally. It's been quite a good experience. So in conclusion, complex regional pain syndrome is a poorly understood severe post-traumatic limb pain, and the affected tissues and the spinal cord and the brain contribute to causing the pain in this condition, but we don't fully understand how this works. Immune modulation therapies have recently emerged, and maybe they're effective, but we need more research. We and others are doing that, and I think regional pathways to promptly identify and treat those suffering from the condition and maintain some framework of care afterwards are advisable.